Thank you, Chairman. I'm Sungkyu from Seoul National University Hospital. I choose the topic intervention and surgery case. There was a newborn baby with hypoplastic left heart syndrome, which was consists of aortic atrasia and mitral stenosis. And this patient was diagnosed with Kabuki syndrome. She had scleroconia and left hip subluxation. You can see small LV and main pulmonary artery to PDA, very small ascending aorta, and pulmonary artery. I want to tell first brief history before hybrid procedure. At the age of 6 days, I performed pulmonary bending bilateral, and then there was we found out the wound problem, and 3 days after pulmonary bending, bending tightening was performed cause of unstable vital sign. But at that time, the wound problem get more worse, and very serious and extensive problem. So we applied vacuum sponge change every 2 or 3 days. But we found out the PDA size was decreased despite of continuous infusion, PG1, and small isthmus. So we have to do something, but it was expected that the patient general condition would not be good after major surgery with a very serious wound problem. So we decided to hybrid procedure, reverse PT shunt with 4 millimeter PTF graft and PDA stenting with open cell type stent to maintain cerebral and systemic perfusion. After the procedure, we apply vacuum sponge again. You can see the puncture to main pulmonary artery and stent here, and interposition of stent into interposed to PDA. The procedure was performed in operation room. The 3D printing model showed the heart after procedure, the yellow colored reverse PT shunt, small ascending aorta, and stent here, and bilateral pulmonary bending. After the procedure, we applied vacuum sponge every 2 or 3 days. At last, at the age of 45 days, the wound can be closed with using bilateral pectoralis major muscle by our plastic surgeon. But around the age of 3 months, hypoxia progressed. So we had to do something again. But we concerned wound problem once again, and how to reconstruct arch after ductal stenting removal and small pulmonary artery size. So I did pulmonary artery debending at the age of 3 months, 18 days. As I expected, wound was not good, but fortunately, we can do primary closure, and there was no more wound problem. So at the age of 5 months, 8 days, this patient underwent Norwood BCPS procedure, take down reverse PT shunt. I used this graft as a arterial perfusion, for arterial perfusion, and Neo-aorta was reconstructed with native tissue-to-tissue anastomosis, and the arch reconstructed with retained stent patch graft. We don't remove the stent. And pulmonary angioplasty was performed, hilum to hilum, with the bovine pericardium. Post-operative course was good, and post-operative CT showed well anastomosis original aorta to neo-aorta and arch here. The geometry of arch is good without any stenosis of bronchus and vein great arteries. But left side arch was small. So age of 8 months, our cardiologist did intervention. You can see the small pulmonary here and balloon improved. This kind of hybrid procedure and modified arch reconstruction already introduced from the Toronto. They said the 4 or 6 months after ductal stenting, they could use without the tissue without problem to suture, and this technique is beneficial to preserve original geometry of arch and widen aortopulmonary space. Now she is 34 months old, 11.6 kilogram. You can see the typical face of Kabuki syndrome, scleroconia. This is X-ray 6 months ago. Now she is okay. She can talk, she can walk. Condition is very good. So, in conclusion, ductal stenting could be a salvage palliation treatment in high risk of hypoplastic left heart syndrome patient. Modified neo-aorta reconstruction with retained stented patch in no-type procedure can be a considerable surgical option after hybrid palliation therapy in case of HLHs with high-risk feature or severe complication. And finally, a multidisciplinary team approach is most important to save your life. Thank you.
Okay, thank you, Dr. Cho, for your great case. Any question or the comment?
Thank you so much. During the meantime, aorta and pulmonary artery pressure and patient saturation change, how was it?
Sorry.
Saturation change, I am wondering, and then the pulmonary artery pressure.
Pulmonary artery pressure?
Yes.
Now?
During the process, probably the change.
Okay, I understand. After first bending, the velocity around 3.5 millimeters second, but I think the velocity can be changed, could be changed according to ventricular function. So I think it was not correct. If ventricular function is good, velocity can be more higher. But the saturation is over 80 or 85. So, and the systemic blood pressure was low. So we decided to do bending tightening, and then the size of bending was 1.5 millimeter. And the velocity also measured very differently in any situation. But we used the target velocity, we adjust around 3.5 millimeters second. Yeah.
Dr. Gotani, do you have any question or comment in this patient?
Thank you, Dr. Cho. Very nice to see you.
Thank you. Nice
Thank
to
you
see
for
again.
showing your challenging case. I had a question because you wanted to wait until you can do either Norwood or hybrid 2 procedure until after the wound is healed, right?
Right.
In that case, you I don't know what's the situation in Korea, but do you have any variety of stent that actually you can dilate when you have or you need to wait more to perform the Norwood procedure? Because
Yeah.
usually we wait until like 6 months or so, right?
I waited 4 months, 8 days.
Mm-hmm.
Yeah. 5 months, 8 days.
Mm-hmm.
And I don't know exactly what kind of stent we have, but our cardiologist said this is open cell type, and we can dilate once again. So we planned dilation or more before Fontan operation.
So the stent was the longitudinally separated, the cut, or it has a circumferential integrity?
Yeah, very good question, because during the node space procedure, I considered to cut, but I worried about the aneurysmal change. So just I resected arch area.
Yeah, okay, smartly the decision, but maybe we have to consider it is at the part of the isthmus, and in the future we have to intervene on that side again.
Very good point.
Thank you.